Spectrum and Epidemiology, the first session. May I take the honor to invite Dr. Jayanti Venkatraman, Dr. S.P. Singh, Dr. Yongi Zabu, and Dr. Atul Sachdev to please chair this session.
I think it's a pleasure to invite Zubair Yunusi to give the inaugural lecture on global epidemiology and economic impact of MASL. Zubair, please.
Well, thanks again for inviting me to the organizers and especially to my friend AJ. I'm going to do what these are my disclosures. What I'm going to do is to present to you this area of epidemiology slightly differently than what you've heard. And I'm going to also set Maru and Alexander with their talk in terms of what we are talking about as a sort of a combined disease of steatotic liver disease. So when we are looking at SLD, I'm just going to talk about these three subtypes: MASLD, MetALD, and ALD. And I just want to remind you that MASLD is an umbrella term. It includes basically MASH and non-MASH. The non-MASH used to be called steatosis alone or fat alone, but really is the MASH subtype, which is progressive. So that's the first point. The second is that when you're looking at these diseases, the spectrum, there is a great deal of overlap between these diseases. In fact, cardiometabolic risk is a requirement for MASLD and MetALD, and you see it in about 95% of patients with ALD. That's the second point. The third point is that historically, even with the new nomenclature, we're thinking about what's called box thinking. We have all these different categories. The reality is that this is a spectrum. Alexander, myself, and Shira Zelbersagi wrote an editorial last week that came out in JHIP, looking at sort of this interaction between cardiometabolic risk and alcohol. And it's dynamic, meaning that it depends how much you drank last weekend or how well your diabetes and hypertension and obesity is controlled. You can go from one part of the spectrum to the other part. Now, having said this, let's just look at the global burden of MASLD, at least the way that's been presented in the past few years. This is the most recent meta-analysis. The bottom line is that when you look at the data that has been published in the past decade, the global prevalence of MASLD is 38%. Highest prevalence rate in Latin America, also in Middle East and North Africa. But when you're looking at the progressive type of MASLD, which is MASH, that prevalence is about 5%. Ranges between 5 to 7%. Now, that is, of course, lower than 38%, but remember, this is about 4 to 5 times higher than hepatitis C. So this still is the most common liver disease in the world. And when you look at this modeling that we published a few years ago, it's expected that in the next 20 years, the prevalence of MASH will go to about 7 or 8%. So it's increasing. Type 2 diabetics are sort of a special group, very high risk of MASLD. The prevalence of MASLD in type 2 diabetics is about 69%. When you look at this region, number of cases of MASH or MASLD in type 2 diabetics is highest in East Asia and South Asia, the highest. In fact, another peculiar thing about this group is that most of the MASLD in diabetics would be MASH. So 66% of MASLD is MASH. And about 41% will have significant fibrosis and 15% will have advanced fibrosis. So a combination of MASLD or MASH in the setting of diabetes is not good. In the pediatric population, the prevalence is about 10%. In the obese kids, it could be as high as 35%. And of course, it's higher in boys, and also it increases with age. When you're looking at the natural history of this disease, this is a cartoon, what you're actually seeing is that most of the NAFLD, almost 70 to 80% of MASLD, is actually non-NASH MASLD. In general, non-MASH MASLD or steatosis alone do not progress in terms of liver disease. Now, there are cases from tertiary care centers that they can progress, but in general, from a liver disease, they don't progress. But it is not a benign disease because it does cause an increased risk for cardiovascular mortality. In contrast, MASH can progress, causes cirrhosis and hepatocellular carcinoma. Again, I'm not going to get into the pathogenesis, but just to remember, this disease can be caused by multiple different pathways. These pathways can be activated, one or two pathways or multiple pathways in a single individual. Wide adipose tissue producing adipokines and cytokines, especially pro-inflammatory adipokines and cytokines can promote this. Gut dysbiosis, oxidative stress, all of these things ultimately will lead to damage to the liver cells that we call, quote unquote, at least initially, balloon cells. The process also leads to activation of stellate cells and fibrosis. And if you've got other things like alcohol or a virus, then of course that can accelerate the disease. The progression of fibrosis here is not linear. It's actually, you can progress, regress. In fact, I believe that this is probably related to this combination of what we talked about, cardiometabolic and alcohol. So if you stop drinking for a while, or if you lose weight, or if your diabetes is well controlled, maybe you will spontaneously regress. That causes problem for clinical trials of MASH because you get high rate of what's called placebo effect, where patients on placebo will improve fibrosis. Nevertheless, when you look at the causes of mortality, in the entire cohort of MASLD, cardiac mortality is the number one cause of death, liver is the third. Now remember, in general population, liver was about 10 or 12 causes of death, so there's a concentration of liver-related mortality here. But once you develop more advanced stages of fibrosis, liver is going to become the more dominant cause of mortality. Now let's get back to the spectrum. Some of the data I'm going to show you is here. I'm showing you for the first time. So this is actually data that we have presented or will be presenting at next AASLD. I'm just going to show you a snippet of it. This is looking at 25 years of enhanced data with 41,000 individuals. There is a methodology that you can actually use to correct for underreporting of alcohol, because we're looking at steatotic liver disease. Obviously, it's underreported by history, but there is a way to actually correct for that. So over the last almost 3 decades, you see that the prevalence of MASLD went from 13% to 31%. Mid-ALD, the way it was actually sort of defined here, went from about 1.6% to 4%, and ALD from 2 to 5%. Now, it's important to remember that ALD is not all the same. You have individuals with ALD and metabolic diseases, and then you have pure ALD, meaning that you have ALD meeting the definition of ALD without any metabolic abnormality. These are usually young females, and I'll show you the outcome of these patients. Now, despite the correction that we used for this, I still think that there is an underreporting, misclassification of MASLD, that some of these patients, if you do PET testing, somewhere between 20 to 40%. Alexander's team, close to 30 to 40%, and at least in the United States, in our serum bank, it's about 20% will have high enough PET values that would be considered either mid-ALD or ALD. So there is still some misclassification that we need to deal with. Now, in terms of outcome, despite being relatively rare, the pure ALD without metabolic abnormality has pretty poor prognosis. Higher mortality, this is premature mortality. And when you look at risk of mortality, the highest is for pure ALD, followed by ALD with metabolic dysfunction, met ALD, and then mass LD. This is, of course, compared to SLD without alcohol. So, and I believe that these pure ALD are young patients who drink and have alcoholic hepatitis, and maybe that's the reason that they have high mortality. What are the types of mortality and causes of mortality? So again, using enhanced data, this is US national data set. When you're looking at overall mortality, premature mortality, or early premature mortality, this means that dying from somewhere between age of 30 to 69, that ALD has the highest mortality, followed by met ALD, followed by mass LD, which is what we all are expecting, but this is the data that shows it. From another study that's actually from NVSS, this is mortality data for the entire United States, looking between 2010 to 2024, premature mortality rates increase in all subtypes of SLD, especially met ALD, as you can see here. But look at the causes of that. So the cause of that was highest, was cardiovascular mortality was highest, and mass LD, but cirrhosis was the number one cause of death, and ALD and met ALD. What's actually more interesting to me is that when you look at cardiovascular mortality and mass LD, it's decreasing. It's decreasing for whatever reason, better care, better prevention, but some of the complication of liver disease, especially HCC, is increasing in all three subtypes of steatotic liver disease, especially mass LD and met ALD. So this is really why we're all seeing more and more liver cancer in our clinics. Another important outcome is liver transplantation. This is also very recent data. This was published last month, maybe 2 weeks ago. For the first time, we combined the two main registries of liver transplantation from the United States and from Europe. Europe has 30 different countries, and US, of course, is the transplant data set that we have. And we have almost 240,000 recipients, liver transplant recipients. SLD, meaning alcohol-associated liver disease, is the number one, followed by mass LD in both Europe as well as the United States. Now, of course, ALD is much more common in Europe than here, and that's true for both HCC and non-HCC. Now, let me show you the global sort of data. As you can see, NAFLD is driving, mass LD is driving mortality in most regions of the world. But when you come to this region, this was just actually analyzed just about a week ago. This is prevalence. This is the prevalence data for Southeast Asia and South Asia. And as you can see, there is actually the highest number of cases of mass LD is in India. Now, the prevalence is actually also pretty high in Malaysia, and also, as you can see, in terms of mortality, again, the number of cases of mortality, the highest. This is from GBD data, GBD 2021 is in India. But also when you look at the rates, it's also high in countries like Bhutan, Nepal, Bangladesh, and especially the rate of change is high in some of these countries. This is when you divide this up in terms of liver cancer deaths or cirrhosis, again, the number of cases are highest in India. We discussed this a little bit yesterday, that's probably what we presume, but here is the data to confirm that is true. Lean mass LD, just last slide on the prevalence, somewhere between 5 to 25% is the prevalence, depending on where you are. When you look at our global registry, it was about 6.9 or 6.8%. When you look at outcomes, the Asian study suggested that it was not associated with advanced disease, but the German and US both suggested it was more aggressive. Economic burden, this is a study of 9 countries, and as you can see, the number of cases are increasing. The economic burden, direct healthcare costs is increasing. What's driving both the clinical outcome and the economic outcome, or this is a very, very busy slide, but makes the point that you have the lifestyle issues, you have genetics, and you'll hear about this in a minute, or in this session later, and then socio-demographic components. We know that increasing component of metabolic syndrome, obesity, and type 2 diabetes are associated with increased mortality. What's actually new, and this is also just analyzed, again using enhanced data, is that regardless of what type of muscle you look at, you'll see that when you have a combination of type 2 diabetes with binge drinking, you have higher rate of mortality. Finally, the issue of social determinants of health. When you look at food insecurity in adolescents, it's associated with high rate of MASLD. When you look at MASLD mortality, and this is again from NBSS data, you'll see that food swamps and food deserts are associated with mortality from MASLD. And when you look at globally, this is from UN food data, you'll see that in countries that are rich, bad food, bad composition of food drives MASLD. And in poor countries, that's actually hunger. That's actually the problem. So there is increasing data to suggest that we're talking about a dynamic spectrum of steatotic liver disease, and I'm sure Alexander will talk about this more. MASH subtype and its associated complications are growing. Clinical burden, economic burden are substantially increasing, and the burden is primarily driven by modifiable risks, and the burden is very, very high in this area of the world. So it needs to be dealt with urgent policy and decisions. And thank you very much for your attention.
Thank you, Dr. Zubair. Please join us on the stage. Please join us and we'll take up the question and answer session at the end. May I now request Dr. Mary to come over and speak to us on MASLD impact of the new definition in the last 2 years.
So I'd like to thank the organizers for the invitation to help direct this course, and I hope you enjoy it, and especially I'm very happy to see some old friends and some new faces as well. So what I'm going to do is walk you through the why and how we got to the nomenclature that we have now. So these are my disclosures. So just thinking about sort of the evolution of the nomenclature, this has really been something that's been in discussion for a long, long time, actually back even as far along as 1980 when Jürgen Ludwig initially made the observation and coined the acronym of NASH. And interestingly, you know, he had a very hard time publishing this paper. It ended up in the Mayo Clinic Proceedings, but it's actually been one of the most highly cited papers. Then in 2002, during a single topic conference on NAFLD, this was also discussed about the different alternatives, but again, a decision wasn't really reached. And then in 2020, in a very provocative paper, the term MAFLD, metabolic dysfunction associated fatty liver disease, was proposed, and in the special issue of Gastro, there was a mention and a short survey, I would say, that was put forward, but there was no formal methodology specifically to reach this consensus, and this consensus panel was, I would say, not very structured. So when this definitions paper was circulated just after this, there were several dissenting views at the time, and these views were not considered. And so this led to the exit of many key opinion leaders, and specifically because of the following issues, just so that you understand why this happened. So the part of the original MAFLD definition eliminated the importance of steatohepatitis, which we found to be foundational as far as development of fibrosis and the untoward effects of liver disease. The impact of having rigid or more significant, more metabolic burden, yes, it causes increased risk of progression, but it also changes the natural history and didn't really recapitulate NAFLD. And then there was a concern over the validity of the process and the role of alcohol and the lack of boundaries for alcohol. So this is sort of what started the process. So we sought to answer the following questions specifically. Firstly, talk about the limitations of the terminology NAFLD and whether there was consensus on this changing or not. We discussed the importance of steatohepatitis and disease definitions and endpoints, and how we should best consider the role of alcohol. We also discussed at length the short and long-term impact on disease awareness of any change, as well as impact on clinical trials and regulatory approval pathways, seeing that we were on the verge of starting to have a new drugs for this disease. And ultimately, can this alternate name reduce the heterogeneity and allow for future success? So we put together a fairly robust panel. There were 264 participants that were nominated from the multinational liver societies. There were 56 countries represented in the process. We underwent 4 rounds of Delphi over a 2.5-year period, and we defined a priori this consensus to be a supermajority of greater than 67%. We had 2 in-person meetings to discuss points of contention and areas where there needed further clarification. And then we published it simultaneously in 3 journals, as you can see here. So this is the overarching steatotic liver disease framework, and as Zubair mentioned, this is really a spectrum disease, and I think more and more we're thinking of it as this, as such, and not really as a disease that should be looked at in buckets. And Alexander is going to really sort of focus in on this in his presentation as well. So I'm not going to spend much time on this, but I do want to mention that the reason why only one cardiometabolic risk factor was considered is because we were intentionally trying to be as broad as possible and include as many of the population that were included in NAFLD so that we could rely on the historical natural history data. I won't go through this in detail because we're going to be talking about it. So just to quickly compare some of the differences between the definitions, focusing on specifically alcohol consumption, which within NAFLD, as you may recall, it is required that you have less than 20/30 for females and males daily alcohol consumption. In MAFLD, this was not required, and in MASLD, we also kept the same criteria as for NAFLD, but we also added this sort of middle criteria called MET-ALD that we've been hearing, you'll be hearing about already this morning, and you'll hear about it more a little bit later. And then as far as requiring the exclusion of other diseases, this is not specifically required with the MAFLD or the MASLD definition. So the first question we asked was, does the MASLD population actually identify those that we referred to as NAFLD before? And on the left, you can see 3 Asian cohorts from Vincent Wong's group. The first, a community sample of patients with NAFLD, and you can see the percentage that fulfilled based on the MASLD criteria and the MAFLD criteria quite close. There was another cohort of incident NAFLD, and that was a bit more accurately represented by the MASLD criteria. And then biopsy-proven disease, also fairly well represented. In the middle, you can see the AFEF, which is basically a large clinical study cohort, and you can see that there was very high overlap. And then to the right, 2 very important papers from this part of the world, Indian real-world cohorts. The first one is a single-center study, and you can see that the focus was more on lean disease, which is a bit more relevant in Asia. And this is an important group that wasn't easily represented before. So 84% fulfilled the MASLD definition, and almost 50% fulfilled the MAFLD definition. In this second cohort, this was a multi-center cohort, 40 centers, nearly 8,000 patients almost 900 that were lean, and you can see that 98% fulfilled the MASL definition and 83 MAFLD. So I think in summary, I think we know better what we mean when we talk about metabolic dysfunction associated with steatotic liver disease. So I'm going to touch a little bit on stigma, and I know this was an important point of contention across the nomenclature process. Why? Because it's going to vary from culture to culture. It's going to vary with language. And these are just some examples, perhaps extreme examples, but just taking HIV/AIDS. So in 1980, this was briefly referred to as GRID, which stood for gay-related infectious disease. And this was very, very traumatizing for the HIV community and patients. And then, of course, COVID-19, to take a more recent example, when it was referred to as the Wuhan virus or the China virus, this really caused a lot of backlash against Asians across the world, and this is something that could have been avoided. So as far as measuring stigma, this is not the easiest thing to do. And again, it very much depends on who you ask. Here is an example of stigma and psychosocial impact across patients with NAFLD, across disease severity, those that don't have cirrhosis, those with compensated cirrhosis, and those with decomp cirrhosis. And you can see that a sizable amount of patients did feel stigma. And then when we looked at it in our own survey in the 2023 paper, 66% of the respondents felt that the term fatty was stigmatizing, and 60% felt that non-alcoholic was stigmatizing. And then also, it actually is stigmatizing to the alcohol liver disease community because it's emphasizing that, well, it's not alcohol, again, which is a bit pejorative. This is a nice paper written by Zobair, published just last year, but put together actually during the time of the nomenclature process. And you can see that there's significant variability from country to country with respect to how stigma is perceived. But the way we looked at it is, if you can avoid having people feel stigma, even if it's a small percentage, you should try and do that. It's really not something you can apply to a supermajority to make that decision. So by reducing blame-based language, I think this certainly helped. It facilitates conversation in cases of MET ALD. It was difficult to say you had non-alcoholic liver disease, and then you also had alcohol-related liver disease. So this, I think, helps the conversation a bit, and hopefully will reduce alcohol underreporting. I think recognizing the metabolic origins of the disease is a way to reframe the condition and really help patients understand the why, and help them, sort of reach a better understanding of how they might treat their disease. And then, of course, there are challenges, as I mentioned, difficult to quantify. And when I surveyed many patient organizations, in general, they felt that this consensus and advocacy feedback really did suggest that the terminology change was helping. So the goals for this process were to get endorsement initially, which we got from over 70 societies, to adopt the use of this terminology in medical literature, incorporate it into billing and coding, adoption and education, incorporation into clinical care, and then to ultimately increase disease awareness. So as far as scientific publications goes, it certainly has had significant uptake, going from 5 citations using this nomenclature to almost 8,000 at the end of July. There has been, I think, good progress as far as uptake across sectors in the research community. I think it's fair to say that there's near universal use of the new terminology. There's a shift towards more inclusive models, which, as Zobair mentioned, major journals and conferences are also either strongly encouraging or requiring the use of the new nomenclature, and is now recognized by the National Institute of Health in the United States, as well as the Food and Drug Administration, the FDA. Pharma actually was very quick to adapt, and they've all shifted their protocols and such to use the new nomenclature. And the diagnostic companies are revisiting test panels that may reflect changes such as those with MET ALD. As far as clinical practice and education, this is where I think we have the most work to do, but we do have some evidence of significant progress, at least in the US, as far as that I've been actively a part of. So the uptake, again, it's, I think, highest, at least right now, in the US and in Europe. Largely related by the push and the very significant participation of ASLD and INASL in this process. Asia Pacific region also had very early and very important involvement by INASL, actually, SASL, Japanese Society, Korean Society, and others as well. And then the rest of the world, we really need again, to continue to, it'll take a little bit more time since resources might be limited in some parts of the world. So as far as prognosis, and I'm not going to spend much time on this, but just it suffices to say that this is, of course, a very dynamic spectrum, as we've been saying. The more alcohol is involved, the higher the risk of hepatic decompensation. And there is relevance to the subcategories, which I'm sure Alexander will talk about, and Zubair touched on, so I won't spend much time on it. I do think it's had an important impact on research. Med-ALD, if you look at publications, of course, it wasn't a known term before, but to about 200 publications specifically focused on this in the second quarter of 2025. And I also think that it's had a positive impact on the alcohol research field as well. It seems that there's increased attention to how metabolic dysfunction can also influence alcohol-related liver disease. And there's, I think, more of an understanding or an interest in understanding variable susceptibility related to genetic and other factors. Biomarkers have actually become much more prevalent, much more commonplace to detect alcohol, as we heard a little bit about earlier. And then thinking about ways to treat both conditions or the spectrum itself, I think is really an exciting development as well. So there are several issues, classification challenges, and open questions, which will be largely addressed by Alexander, and that will cover, at least to start, the dynamic nature of alcohol and the shifting in categories, how to manage historical alcohol use with respect to the natural history and response to therapeutics, and then considerations on efficacy and safety in the context of active alcohol use. So to close, I think an actionable classification is what we have right now, categorization that guides effective treatment decisions. And it's also, I think, what we have currently is fairly practical. We've used the best available evidence and can make diagnoses with current tools. And then I think the perfect classification, although you'd think that it would be something to strive for, I think it paradoxically make it more difficult in a sense. So I think that we should continue to evolve and discuss and strive to achieve a nomenclature and definitions that best suit our patients. So this, I think, just recapitulates what the process has been like for us, but I really think we're entering an era of very significant productivity, and I think what's become a very exciting new field of research, which is Med-ALD. So I think we do know better what we mean now. I think the name and definition highlight the underpinnings of the disease with metabolic dysfunction at the center. More focus is needed on the potential role of alcohol, and I think that's really been an important focus. With Med-ALD, nomenclature evolution and the definition and operationalization of Med-ALD have substantially influenced research and clinical practice, and there's increased interest in pharmacotherapy for both conditions. I think the global uptake has been generally robust, but we need more education. And I think most importantly, what this has done is stimulated discussion, debate, and further discovery. And I do think we, of course, have much more to do, but solving these challenges will require ongoing international collaboration like we're having here today. So with that, I'll close, and thank you very much for your attention.
Am I audible? Yeah. Please join us here. And for the next talk in this session, may I now request Dr. Alexander Cragg to please talk about mortality, managing the dynamic nature of alcohol intake.
Yeah, first, Good afternoon, everybody, and I think a huge congratulations to INASL, to Deeman, to Taneja for organizing this meeting. And it's wonderful to come here again and to see how INASL is evolving. I think in terms of quality, in terms of impact, in terms of ambition and vision, but also this international imprint. So that's really fascinating. And I think the superpower behind at the moment is AJ. So I hope you will congratulate him. And also I think from ISLA I can say that we've enjoyed very much and still do this interaction with INASL and our friendship. So in extension of the two wonderful talks, my job is to discuss on how we understand and manage the dynamic role of alcohol intake. So these are my disclosures. And then there's this figure. Nobody knew it, whatever, a few years back, and now we cannot do any talk without having this at the second slide. So this is sort of the framework. This is how we see. This is the map of our world, the steatotic liver disease world. And I think we've heard something here that's, just recapitulate a little bit, but in my view, now looking back and trying to see what was the most important, the most defining and changing, impactful thing of this nomenclature. And we'll see if you buy my argument, but I think it's actually this thing here in the middle. Zubair, he mentioned how MASLD, MASH is the same, 99% as NAFLD. Nicer name, fine, but we got it. Alcohol also more or less, same. Let's not discuss that. But then, the way I see it, and I thought here reflecting, is that the way this has been working, it has been just like two siblings who have not seen each other for as long as they can remember. They almost forgotten that they existed, the MASLD and the ALD. And I think they almost forgot that they were a part of the same family, and three researchers also forgot it. So what was the brilliance, and a big kudo to you, Maro, and others, for bringing this together? Because I think the one that was bridging these two things and actually brought that SLD family together was selling and having people understand and buy in on MedALD that sort of connected the dots. So having said that, so that was sort of the praise for that, and that's wonderful, and it's really defining. Now we come to all the criticism. So that's where we start, because I think this is a consensus-driven process, what happens when that meets reality. So the concept of this, and that's how we work, how our brains work, how our textbooks work, how we act as doctors. We need boxes. We need people to put into boxes. But biology, human behavior is dynamic. I'm trying to explain that, and back to something of the thing that Zubair and also Maro mentioned a few times. We're increasingly learning that this is not so clear. And in reality, these borders are not so clear. And there's a lot of movement which I'll try to show to you. So yes, we need the boxes. It makes our life easy, and it's been wonderful for research. Whatever, 7,000 to 8,000 papers. Now it's very easy. You just put them in a box, and then you push submit, and then you're almost out there. But the question is, want to challenge it, to what extent does that represent reality? Basically our clinical world, and can we learn more, or should we think differently, and how do we manage that? So I'm sure in your head, Maro, it looks like the one to the left, it's all ordered, and your textbook. And many of us are more like to the right. We are chaotic, dynamic, and it's basically the reality of impermanence. So there are many things in our world that makes it more chaotic. I'm sure it would have been difficult, Maro, to publish the picture on the right here, but I think in many patients and many people, that is kind of reflecting their reality, that things are moving more than we think. The question is, how do we understand that as researchers? How do we make that actionable as clinicians and drug developers, whatever? And that's a challenge. I have no answers for that. I can only put forward problems. So maybe you can help me. This is patients we had in a trial. Can you explain what subcategory in steatotic liver disease is this patient fitting in? What diagnosis can I give this guy? So I have to admit that if you take the index, he was in an 18-month trial on alcohol-related liver disease. I don't know, I could imagine him in a MASL-MASH trial. I could even imagine he had a TE of 15.4, a F3 fibrosis, he would be eligible for resmetirom therapy. However, he's been drinking for 15 years, and then he stopped up to this. And then, as you can see, it moves back and forward, and on the average, he has. So that's the challenge we have, that some people look like that. And then you say, okay, nice story, but is there more to it? So Based on this, we tried to look into a larger cohort. This is more than 1,000 people we looked into, and just took the cross-sectional approach and say index, and then 2 years down the road, what category would it fall in? Very, very simple study. And then you can see here in this Sankey diagram how it goes. There's a lot of people moving between these borders I mentioned, and some cross 2 borders even without a visa. And here you can see it actually amounts to a significant number of patients. Of course, we will probably soon have more studies like this, but it's been known for the alcohol literature that alcohol is not a linear thing. It actually changes over time. So I would expect that this is not just a Danish thing, but let's see. But this has impact for how we manage the patient, because if you don't know what is the lead driver of the disease, how can you then treat it and approach it? So what are some of the explanations behind this? So to the right, we got our, let's say, defining things, metabolic risk factors, steatosis, alcohol, but what can affect these and our behavior around these? And there are many, many things that are not static over time, that are dynamic and susceptible for various things in people's lives. So that could be it. However, now I said, okay, it's all a mess. And yet, then going into trying to validate this nomenclature. Mauro also showed these slides, but it's interesting to see if you then have, and again, an observational setting, you classify patients, then there's a clear separation in terms of risk of decompensation, so real hard endpoints, and also mortality. So it works, but there are problems. That's pretty much where we are. Yet, there's another thing which I want to also show and expose you to. I think is part of the story of how to understand and try to comprehend this dynamic nature. We have what we label steatotic liver disease burden paradox, because I cannot explain it. So Bear had all these wonderful epidemiology slides and also opened a little bit out into underreporting. I'll come back to that. We have a very high prevalence of one part of the subcategory and low on the other one. But when we look to our clinics and the impact on mortality, transplant, etc., it's still alcohol that drives the clinical. So there is something there we cannot really explain. So I think part of the explanation is what I want to dig into now. It's about the reporting. So we have a very small fraction, or we have a huge chunk of the population that is steatosis in the liver. Small fraction that's because of alcohol. Yet we know that in most or many countries, at least in Europe, United States, and others, most people drink. A lot of people binge drink, etc. So there's a significant exposure to alcohol. So what is popping up around now? A lot of research papers, so Bear mentioned them, and is that the underreporting. They range from maybe 10% in the most controlled setting, that's the RCTs, and then you have maybe in observational studies or studies where you have cohorts where you think they have MASLD, then whatever, 25, 30% probably have ALD, mid-ALD, something like that, and clinical observations. So now just follow the slides to the right. So the left is just the different studies that show what is the underrepresentation. But what would that mean in terms of the distribution of the prevalence of the steatotic liver disease subcategories? So if we correct 10%, 25%, or 50%, suddenly a lot more of this is actually attributable to alcohol, and alcohol makes a difference there and could be an important factor both in our treatment and our clinical approach. And what's behind this? Why don't people just tell us what's the problem? I think there are many reasons for. Mauro talked about stigma, and it's very difficult to study, it's difficult to understand, but there's certainly something what we call intentional, or let's say that's part of the shame, the stigma, the cultural or religious thing. And then there's also a huge, I think, unintentional part. Recall bias. I don't know, if you guys look back a month, how much did you drink? How often did you drink? It's not so easy. And what is a standard drink, by the way? Some of these issues makes it challenging. So trying to give this, challenging what we have put in these nice boxes, I want to say, okay, what can we do then to understand it better? Find out where the patient is and how we want to monitor them. So what I want to say that if this is the world for many of our patients, so a bit more chaotic way of seeing the subclasses, how do we manage that? I think the key thing is try to understand how much do people drink, and that changes over time. This is actually from the MASLD guidelines. It's a nice overview of this. Okay, I told you already that standard self-reporting not so good. These are the Indirect markers, sensitive but not specific, basically not very useful. I would like to suggest that you implement or use to wide extent audit C and PEth, phosphatidyl ethanol. First, a little bit about PEth. PEth is a breakdown product of alcohol and the non-oxidative pathway, and then it's embedded in the erythrocyte membrane as a phospholipid, so it sort of represents alcohol use within the last 2 to 4 weeks. And this is just a study. Again, to the left, you can see again how patients are moving if you measure between 4 time points. Again, the same, different study, but same observation. And to the right, again, some support that PEth is a good, because there it shows that PEth is prognostic. And that's measuring on that slide the decompensation-free survival, it's a clinical relevant thing. And the point here is that it does it better than self-reported. Then about audit, it has been promoted by WHO since 1978, and still, I don't know with you guys, but many places I hear or teach, we still don't use it. So that's a bit sad, because it's a very good and useful validated tool. If the full audit is a problem, I guess the simple audit C here, just frequency, how often do you drink, how many units, and how many do you have, what would be more like a binge type of pattern, and then you can get a good information there. So how do we use these? So what we suggest is a review a few of us did, including Maro, and just coming out in JHIP, trying to see, okay, how do we use this tool? So on the top you have the 3 categories, sort of the playing field, cardiometabolic risk factors, alcohol, and hepatic steatosis, and the challenging one here is alcohol. So we suggested what we call triangulation. You have the self-reporting, and then you have the PEth measurement and your audit C, all pretty quickly and easy to do. And then you work down here. And what we also learned in some of the papers, I'll mention some of them tomorrow in the debrief from INASL, is that people don't over-exaggerate the alcohol. The problem is the under-reporting. And basically then you see what is the concordance between these observations. And then you can also use the audit C, and then try to come into a better way of using it, and then finding out, okay, what is the treatment goal? Is there any shift in subclasses? What does it mean for your treatment approach? And when should you, suggestions for when to reuse it? That could be an acceleration in the disease or something like that. So have a look at it if you're interested. But back to my point, raised also both by Zubair and Maro, I think some of the conclusions we can make already here 2 years down the road of the nomenclature is that it seems to be pretty robust. It brought the world together. It reinforced a massive amount of research, but we cannot see it so categorical. We need to understand it as a dynamic spectrum of disease, and also approach, I think, our patients like that in the clinic. And that's, again, I think, gaining more momentum. This is also a recent thing. Bear also referenced that, about how we should try to reframe this as a dynamic spectrum, and try to, again, better understanding what are the implications for a clinical practice, clinical trials, and how does that affect outcomes, and better understanding placebo response rate. There might be some important information hidden in this underreporting, or better understanding the movement between these categories. So just to conclude on this, to trying to understand or see what is the impact of this dynamic role of alcohol, I think it's very well documented now from various publications across the world that ALD and med-ALD are underreported. That's an issue, when we should, I think, as the index, easy to use, relatively cheap tools, the audit C and PEth. And I think the SLD, we have enough data to see this is, for many patients, a dynamic disease, and allocation to subclasses. You should actually, with some kind of frequent interval, reassess, is this patient still in the same category, and that this is not a once-in-life diagnosis. And we should see this not as a box thing. We can do that for research, and we also need that for clinical trial. But for the individual patients, we need to see that this is more of a dynamic concept. Thank you very much.
Thank you. I hope you all enjoyed this fantastic talk this afternoon. So this session is open for questions now. We have the microphone, so if you come up, please identify yourself and ask questions. Before we start, I just wonder, this is a question kind of a provocative to all of our speakers. We talked a lot about the alcohol affecting muscle, and all these dynamics of alcohol use and effect of that on disease progression. So can you comment on the metabolic dysfunction associated risk factors and how that will affect all of this? Because I think our focus is now so much on alcohol, whereas we know that people who are obese may lose weight, their insulin resistance may get better, but I assume that that would affect the dynamics of the disease similarly. So what do we know there?
Yeah, maybe I can start. So it's again that this is part of the same family, and there's also again a lot of emerging more data. So we saw there's a clear separation. Alcohol, it just makes metabolic risk factors more dangerous, and that can be a factor of whatever 5 to 10. So if you have significant alcohol consumption and then a whatever BMI 35 and type 2 diabetes, you're really high risk. And of course, when you're debriefed tomorrow from INASL, when you do some of these population-based studies, this is the category. That's where you catch people. We cannot tell that, but alcohol is probably not that dangerous if you are lean and don't have cardiometabolic risk factors.
I think the only thing that I can add is that alcohol, even if you have a history of alcohol and binge drinking in the past, and you have not been drinking, but if you have a history of binge drinking and you have a mast cell diagnosis, the outcomes are worse. There is higher premature mortality for this patient. That's the most recent data we have shown.
Zubair,
That's obviously very kind of, if you look at mechanisms, that's some of the epigenetic changes that alcohol causes. So that's something that people cannot escape, even behavioral changes later. So
maybe also an important note for that, alcohol by itself, of course, can cause hypertension and dyslipidemia, hypertriglyceridemia, and of course, the more advanced also insulin resistance. So these are tightly interdependent, and if you then remove the alcohol, you're likely some of the cardiometabolic risk factors will also improve.
So let's take some questions from the audience.
Yeah, I'm Anil Arora from New Delhi. My question is to Professor Zubair. Sir, you said over the last 30 years, there is a compartmentalization of mast cell. 70 to 80% is mast cell and 5% is NASH. So are there different phenotypes, or is it the fat which will trigger the inflammation? Why is it that mast cell remains mast cell for a long period of time? So you still don't believe in first, second, third theory?
So I think some patients will actually start as MASH. So the 2 and 3 hit that we are talking about happens really very quickly, and they just progress. There are some patients that start with just simple steatosis that can get a second hit and a third hit. In my view, those are probably the smaller number of patients. This may be the group that will have a second hit, and that second hit may be a period of time where people are drinking and then they stop, or something else. But I think the point that Alexander, Mauro, and I are sort of making is that we probably should look at all of this as a spectrum. The only thing with the distinction between simple steatosis and MASH is that we don't want to oversell this to especially non-hepatologists to say, half of the population of the world have mast cell D, and that's a liver disease. That's just not true, because what mast cell D is a risk for liver disease, and the subgroup that has MASH is the one that will cause liver disease. Is it a benign condition? Not at all, because these patients do die of heart disease, and so there is a risk. But in terms of liver disease, is the MASH that will progress. And that's really the group that we need to focus on from a liver standpoint. But from a public health standpoint, we need to focus on all mast cell D, because that's how we can get to the attention of the public health and the policymakers.
And in recent data, you showed that pure alcohol, especially in females, is worse than a combination of the two. So won't a diabetic or a metabolic as an add-on factor even in females who are drinking alcohol will be more detrimental than pure alcohol alone? So that was something not
Yeah, I think, when you look at the databases like this, there's always some nuance to it. But in general, I do believe that if you have type 2 diabetes and if you drink, even in moderation, or if you're obese and have type 2 diabetes and you actually drink in moderation, that's actually more detrimental. than if you don't have it in that context. Now, when you look at pure ALD patients, those are the patients that probably have significant more alcohol consumption. Those are the young kids that come in with severe alcoholic hepatitis, and usually if they don't get transplanted, they die.
Yeah, and to put a number to that, so even if you're a person who has an elevated waist circumference, the risk from even one drink is about fourfold. So one drink a day. So it's very significantly magnified by abdominal adiposity.
Zubair, in your slides, Zubair, you showed that, among the ALD, pure ALD was the predominant group. But I have an issue here. How to define pure ALD? Because in our population here, almost 70% of the healthy population have dysfunction, metabolic dysfunction. They have two risk factors. So once they start taking alcohol, they have ALD. 2/3 will be having two metabolic risk factors.
Yeah, and the United
So
States
they won't
is
be pure. And what's your definition?
So the pure ALD is not to have any component of metabolic syndrome, meaning that they don't have obesity, they don't have hypertension, dyslipidemia. And remember something, the prevalence of that currently is 0.05%, very small number, because in the United States, probably 90-95% will have at least one component of metabolic syndrome. So this is a very small number of people. Usually they're young. They're young kids that drink quite a bit and develop bad liver disease. So they don't have yet sort of the time to develop metabolic abnormalities. They could, but they don't have it, at least by definition.
Dr. Anand.
I have two questions, one for Dr. Alexander. You brought out a very nice point that the alcohol consumption is very dynamic and it changes over a period of time. My question is, whether a person is drinking 30 grams, 60 grams, 80 grams, or 120 grams, how does it make a difference in management of the patient?
I think it makes a big difference. So first of all, as we've shown also, the more alcohol, the faster you progress. But also we got quite a lot of tools to reduce alcohol consumption. If the patient then have a hidden alcohol consumption, you don't talk with them. So the whole thing about the brief intervention, you have different drugs that sort of targets the addiction part of alcohol. So I think that's very important, that if you don't know what beast you're up against, it's very difficult to treat it.
But you'll be asking them to give alcohol up in any case.
Sorry?
You are going to ask them to give up alcohol in any case, isn't it?
I don't understand.
You are going to ask them to give up alcohol in any case.
No, I think, yeah, you can do that, but you also know that's not realistic. So if you have a patient, again, if you look at the data, it's very important. Let's say you drink, as you say, 80 grams a day. If you can go down to 40, that will improve your liver risk. That's back also to the PEth things. Okay, we should apply some similar way of see, are there different targets we can agree on the patient? What is realistic? Just like you do with weight loss or whatever. You cannot have all people lean, and they could say, okay, maybe some people can never stop drinking, but a big impact on their risk, not just the liver-related risk, but also the cardiovascular risk and the cancer-related risk to reduce alcohol consumption. And there I say, no, it's just, that's what we did in the past. We just said, no, they could drink anything, and that's for most of the patients not super realistic. And then rather have that as I say, that any reduction is relevant for you, and any reduction will likely improve your or decrease your liver-related risk. And then you can have all the different types of tools, whether they be more psychological, motivational oriented, or you apply different types of drugs to basically achieve that goal. And then on the same time, and that's why we cannot see this in isolation, you take all the cardiovascular risk factors and optimize treatment of them as good as possible.
So great, we are running out of time, so maybe you can follow up with the next question in the break. Let's go to the last question, and quick question, quick answers, please.
Second question is for Dr. Rinella.
I think Nipun
Should I not
question.
ask?
I think Nipun should ask the last question and then we wind up.
My question is for Dr. Rinella. Metabolic liver disease causes MASLD, which progresses to MASH and subsequently cirrhosis over a period of decades, about 3 decades or so. Alcohol, on the other hand, causes cirrhosis in a short period of time, say about 3 to 5 years. Is it wise to combine these two together in MET-ALD? Because what you are going to get in MET-ALD is the effect of the shorter duration disease rather than the longer duration disease.
I actually think that's the reason why you do need to put them together, because I think that understanding and having that open conversation with patients about understanding the magnitude of their alcohol intake will significantly impact their disease course. And so I do think it's really important to put them together for that very reason, I think.
The question is very quick. In the natural, these definition of SLD, the pure MASLD and MET-ALD, when we try to look at the outcome of these patients, we don't adjust the fibrosis state, because per se MET-ALD has a spectrum starting from simple steatosis to fibrosis to significant fibrosis to cirrhosis. So when we say that MET-ALD is at high risk of significant fibrosis or advanced fibrosis, it is kind of reflecting the patients who are presenting to that database, right? So these patients might be already having at high risk of already having advanced fibrosis to be entered into a database. So these database studies, I think, because I have basic data to support that after adjusting for significant fibrosis or stage of cirrhosis, actually the outcomes, liver related outcomes, are almost similar in patients with MET-ALD and ALD, but that's a limited cohort, and the cell death levels are also similar. So what's your take on this? Is it the right way of thinking?
I think the only comment I can make is that this is really looking at sort of generalities and large number of patients. For an individual patient, I think there are other things that are involved that we are not actually taking into account here. You're not taking into account the environment. You're not taking into account sort of other things in terms of diet and composition of food. So for an individual patient, that may actually be different, that the progression or risk may be different. But for a group of patients, this is what we are actually seeing, is that when you categorize patients into these categories, that you do see actually sort of gradation of increase based on the amount of alcohol and the number of metabolic abnormalities.
We conclude this session now. I thank all my co-chairpersons and the speakers. Thank you.
Thank you very much.